Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello and welcome to another episode of Doc Talk with Monument Health. My name is Mark Houston, and joining me again is Dr. Luis Hernandez from Monument Health, specializing in general cardiology. You've got the interest in heart failure, and that's kind of what our topic has been here over the past few episodes. And I have to ask, because it's been really kind of bugging me here over the past couple. Why did you decide to get into this, doctor? I mean, it seems like such an amazing field to study. Well,
heart failure is a new exploding field. It wasn't as interesting, I guess, a couple years ago. I would probably say in the last 10 years just blew.
Really?
Especially because we have more information. We know more than before. Now we have more, we know more about transplants that we didn't know nothing much, years ago. Obviously, technology is improving. People can have a normal heart with, normal life with a new heart, for example, with a transplanted heart. Now we have pumps, for example. People can have a pump. It's a little bit different story,
Sure.
though, but kind of similar. But in reality, the reason is why did I pick this?
Yeah.
Especially knowing that there is a lot of sad cases, but I think it's for me is seeing how their life changed. Seeing that patient being very sick, and then with your help and whatever you do, it can be like a medical therapy, it can be a transplant, it can be a pump. Whatever we do is seeing that patient getting from being sick to being better. I think that's the most rewarding thing you can see in your life.
So even when you were a young boy in Honduras, did you still have these thoughts of like, I want to be a doctor. I want to be. This is the path I want to take.
Yes, actually, being a doctor in general, I always knew it. A lot of people say, "Oh, I didn't know until I was until went to high school." I always knew it. I don't know why. My dad is a mechanic. My mom is a teacher. So we don't have any doctors. I'm actually the first doctor in my family. And, even though my dad never went to school, one of the things I always appreciate is like he would never crush my dream. You will expect that someone who never went to school will say, "Oh, you cannot do this. You should be a mechanic." Or no, my dad, I always told him I want to be a doctor. And then, God gave me the opportunity, and here I am.
Well, it's interesting, though, because your dad could go into the engine of a car and replace an alternator with another one. And now you're you're taking that to a much grander scale. You're keeping people alive.
Well, to make it, real and truth, we have to give part to the surgeons if we do a transplant because they do, but then the rest is my job, though.
Yeah, your job is to make sure that once that transplant or those pumps are in, that these people are living their best possible lives.
Exactly.
Until it's
just time.
Yeah, exactly. So we've covered living with heart failure. We covered in the last episode, we talked a little bit about COVID and heart failure, and that's still
still a thing.
You mentioned, I believe, that you don't really see an end to it anytime soon. Yep. Hopefully, we'll be able to deal with it like the flu.
And I forgot to mention, there is some, and this is common in general, not just with COVID. It can happen when someone has like a big impact, a big news that impact the patient's life, or even by having a stressful event. And COVID actually can cause what we call stress cardiomyopathy. So your heart can get weaker just by being stressed.
Just by getting super excited about something too.
Exactly.
Could probably happen.
Exactly. So, it's more common in females. So you're probably safe.
Well, the nice thing is that I don't cheer for a lot of professional sports teams that win, so I don't have to worry about that.
Okay, perfect. Fair enough.
What I think we want to talk a little bit about in this episode here, which is probably one of the biggest factors, I think, in determining or causing maybe heart failure, and that is diabetes, which unfortunately is way too common. So I'm assuming that having diabetes is a big risk increaser.
Yep, it is. And I think we should touch bases a little bit of not just diabetes. We're going to talk a little bit of high blood pressure.
Okay.
And a little bit of obesity, because I think the three of them are like very linked together.
Sure.
Diabetes itself, just by having diabetes, it increased 2 to 4 times your risk of having heart failure. And the patients always ask me why, and it's very simple. Diabetes causes a lot of other damage to other parts of your body. It damages your kidneys, it damages your heart, it damages your eyes, so it damages the vessels. It is a high increaser having blockages in the heart. So remember what I mentioned before. What was the main cause of heart failure? Blockages in the heart.
Right.
So because of that, you have a high risk of developing heart failure and any other, heart disease in general.
What causes heart? I mean, I guess you just kind of explained that. What causes the heart failure in people with diabetes? But you were talking about obesity as well, which is another big deal.
Yeah.
And like you said, they're all just kind of tied together.
They are kind of linked because if for example, most of the patient who has diabetes will have high blood pressure.
Mm-hmm.
And the way I explain to my patients is because we do have what we call, we do have diabetic cardiomyopathy. So cardiomyopathy means that the heart is weaker or damaged or what, that's the easiest way to explain it, I guess. We do have hypertension, which is high blood pressure. So we do have hypertensive cardiomyopathy. So we have all this similar. The obesity itself has its own type of cardiomyopathy, which is typically preserved or normal or stiff heart. So they're all combined because all patients who are diabetic are most of the time are hypertensive and most of the time are obese. Okay, so the three of them working together, cause problems in the heart. So the mechanism of diabetes is kind of complicated. It's not going to be easy for me to kind of I will try to explain as much as I can, but it's very hard because there's a lot of things involved.
Well, and there's different types of diabetes.
Yes.
Is one type more prone to heart failure than others?
Yeah. So there are a bunch of diabetes, by the way. Mm-hmm. There are a bunch.
Oh,
there's
okay.
two big ones, which is type 1, which is the genetic one, or familials. But, there's familial diabetes. And then we have the type 2, which is the most common.
Okay.
Okay, so if you ask me which is the one that's most likely related with heart failure, most likely type 2. Not because we don't have much of type 1. Well, not because we don't have others. It's because we do. It's just the most common, at least 90% of the time, will be type 2.
Okay.
So the type 1 is that one that is more in young people rather than old people. So the type 1, we do have cardiomyopathy, but it's not as common as the other one.
I see. Okay. So what somebody that comes in to you with diabetes, what is the next step then? What if they have that heart failure? Is it similar to just having a heart failure from any other type of situation, or is there special steps they take because they're diabetic?
So it's the same. It's the same. The difference will be that you want to make sure they're well controlled from the diabetes standpoint. We need to work together with endocrinologists to make sure they get the most optimized, medical therapy for diabetes. Because let's say you have no other disease except for diabetes, right? But if your diabetes is not well controlled, then you can develop diabetes cardiomyopathy. Just by having diabetes, you have a higher risk of blockages. So you can develop heart failure too.
Oh,
so
okay.
the main goal or treatment is to try to control your diabetes, which is a little bit controversial because we know too that very tight control is bad. So it has to be a balance. The ideal will be make sure that people do exercise to kind of reduce the risk, but you still have the higher risk. It's hard to just get it away.
Now, and diabetes is a pancreatic failure generally. Now, if somebody can get transplanted, let's say a pancreatic transplant, can that affect then the heart failure? Or once you have the heart failure, it's there, right?
First, I don't know much about transplant of pancreas, right?
Well, maybe, or can you transplant?
I think you can.
Okay.
I don't know though. let's imagine that we can. So probably the answer will be no. And the reason probably the answer will be no is because the damage is already done. Unfortunately, once people get diagnosed, they were probably diabetic for at least 4 or 5 up to 7 years before.
Okay.
It's just the sugar or the levels of sugar, the glucose was not as high, and they were still not being diagnosed. So most of the patients are already like pre-diabetic, and they really don't get diagnosed until very late. And that's one of the things that's why prevention is good. Prevention is a good thing. And unfortunately, those 7 years already passed or 5 years already passed. You didn't get diagnosed until now. So there's already some what we call microvascular damage, meaning that the main vessels are damages. And again, they all have a higher risk of blockages in the heart. So there's a chance that that's already there. Obviously, there is a component of genetics when we talk about blockages, the component of diet when you talk about blockages, but just by having diabetes itself is a high risk.
So when people are on a lot of medication for diabetes, I'm sure one of their biggest concerns would be, well, now going to be a lot of medication for heart failure too.
Yes.
Do most of those medications play nice with each other?
They do.
Okay.
What is interesting, though, we have a new medicine. I'm not going to say names, because they are very complicated, but we do have a new heart failure medicines that it was originally, or still actually, a diabetes medication. So sometimes, like say my patient is pre-diabetic or in that kind of low range, and I use it for heart failure, I'm basically hitting two birds with the same stone.
Right.
So I always explain them, this medication was invented for diabetes, but, in a lower doses for heart failure. So in those patients who have diabetes, we can use the higher dose for diabetes to replace one of their diabetes medication. And we can have that. That's the only medicine that can kill two birds with the same stone. Okay. The rest are totally different, though.
So when somebody does have diabetes and is diagnosed, you say usually it's a 4, 5, 6 year before. Do you recommend that they get tested for heart failure, even as soon as they find out? No, because there's no way we can prevent that. I mean, we know, again, if you get diagnosed for diabetes, so make sure you get treated for diabetes. If you have high blood pressure, make sure you get treated for high blood pressure. If you have, if you're obese, try to lose weight, do some exercise. So those are the things that you can do. But doing a test just to figure out if you have it, I don't think is appropriate. You don't want to get something that you never had before. Right.
So I don't think there's anything in guidelines that say that you need to get. I mean, it's very vague.
Yeah.
There's some people who get, I guess, risk factors. So it will depend, though. But I wouldn't recommend it if they, just to figure it out.
Okay, I guess that makes sense too, because like I said, there's no cure for heart failure.
But remember, you're not alone, and we can make them better.
I still absolutely love that. We talked about that earlier, that so much of this is communication. And I think it's that way for almost any, relatively serious medical procedure. It's scary because when I started this and I saw the term heart failure, I thought, oh my God, that just means that there's no hope, And I think talking with you now, there's nothing but hope.
Exactly.
In some instances.
There's a lot of things from medical therapy, again, to the worst case scenario, which is transplant and pumps. You still can have, incredibly, people with pumps can have a normal life.
What is the main difference? Well, again, this will sound like a stupid question, although you told me there aren't any.
Exactly.
There aren't any.
Exactly.
What's the major significance between pumps and transplants?
Well,
again,
one is an organ.
Could be a stupid question, right?
No, that's okay. One is an organ, and the other one is a pump.
Right. Explain the pump a little bit more.
Yeah. So the pump is basically goes in the left ventricle, which is the left side of the heart. The heart that pumps to the body. So the pump goes in. It's getting inserted surgically. So you need a surgeon to put it in. But because it's a pump, it has a motor. It needs something to move. So you need energy. So interestingly, it comes with a cable from your belly. You have the cable that come out from your belly, and then you're connected to batteries. You, in theory, can have a normal life in the sense that you can, if you want to do exercise in a gym, in a bike, you can. The pump will help you to do the normal things you do.
Okay.
What is the difference between a heart and a pump? And the way I see it, to explain people and make it easier, there are things, the quality of life with the transplant probably can be better, because, for example, you cannot get into a pool with a pump.
Sure.
Because remember, you have a basically you look like a TV though.
Right.
Like a cord coming up from your belly. Yes. They need energy, so you look like a TV. And then you cannot get a TV in the water. Right.
Yes. Well, you shouldn't.
Exactly. So that's one of the things. That's one of the things that you cannot do. So if let's say you're a swimmer, and we have to decide which one we have to use. That's something we take in consideration. Obviously, we prefer. Now that we're talking about that, I think it's important to people understand. I had a patient who told me that she was too old for a transplant. We do have a time frame, or a year, but typically up to 69 to 70 is still considered okay for a transplant, which is important to know because she was 50, and she thought 50 was too old. So we don't have. If you are a good candidate, you can have 69, you can be 70. Even a good 71 can have a transplant.
Sure.
So there's no age limitation. So I think the difference will be quality of life. Again, there's pros and cons because if you have a heart, you need to be taking medicines to make your immune system lower. So you have risk of other things. If you have a pump, again, you look like a TV, but you still can have a normal life. You need to be taking blood thinners because you don't want any clots in that pump.
Right.
And then because there's, a pump, there's some activities that you're not allowed to do.
Okay.
Yeah.
Now, how is real quick here, how is the pump different from a pacemaker?
Oh, a pacemaker is very simple.
Okay.
A pacemaker is kind of like, I guess, like this size.
Sure.
What size will you describe
I would
it as?
say, well, it looks like the size of you put a couple AA batteries together.
Yeah,
maybe
probably.
something like that,
Yeah,
maybe a
so
little
it's
bigger.
Smaller.
Okay.
And that one has its own battery. And because it's only pacing, so it's only sending a pace spike, the battery can last up to 10 to 12 years.
Now, is a pacemaker used at all for heart failure, for any type of, it is?
No,
Okay.
that's another good question.
Yeah.
We actually do. And it's
Okay.
important. We didn't talk about that, but there are two types of patients with heart failure that require a defibrillator.
Right.
Not directly a pacemaker. They're similar. So pacemaker, the only job is to pace.
Mm-hmm.
Make sure that it will make the job of your normal pacemaker if it's not working. The defibrillator has an extra coil that will give you a strong shock to the heart when someone have a fatal arrhythmia. So people who had heart failure, if the heart is very weak, they are more prone to have arrhythmias. So those patients need a defibrillator.
Oh,
And
I
there's
see.
two types of defibrillator too, which that's a different story though. But kind of like that's the main, I guess the main
Sure.
thing.
Well, I want everyone to know that if you are worried about heart failure and if you have the symptoms that we've gone over before, I don't think you'll be in better hands than with Dr. Hernandez here at Monument Health. I mean, it has been just a pleasure to talk with you and to feel reassured. Again, I think that's the one thing that is most important when people come in because it's a very scary topic to hear about, but just knowing that with the right treatment, your life
Should be normal.
Should be just as normal as anybody else.
And remember, you're not alone.
Right.
Right.
I want to. That should be the tag for this now, since you're kind of the first one here, Doctor. I should have that. Doc Talk with Monument Health. You're not alone. I absolutely love that.
I think that's one of the things I told my patients. They're not alone. I know it's a scary diagnosis at the beginning, but then when you hear about it, again, as you asked me, why do I like this? It's just seeing patients' life change. And I had patients. Right now, actually today, for example, I saw a young lady. Her heart is weak, and then with medical therapy, her heart got better. So my point is, we can get the heart stronger back to normal with the right medicine. So you can be cured, but you still have to take your medicine,
right?
Though, you know.
And I mean, it's exciting for you because you are taking off for a fellowship, I believe, back to Florida.
No, Clinic.
To Cleveland Clinic. That's it. And it's going to possibly lead to the ability for pumps and transplants here at Monument Health.
And that's what I tell people. We have everything at Monument, not just because I work there.
Right.
I'm very honest about it.
No, you can be a little.
But we have no. We do have everything. I really don't have anything that
Sure.
I don't really think there's nothing that we don't have that we need for the heart. And
Excellent.
the only thing we're missing is the pump, which
Yes.
we're planning to do it hopefully in the next couple of years.
That's very exciting.
Yes.
Dr. Luis Hernandez, thank you so much for talking with me here over the past few episodes. And I really hope that we get you back and let's talk some more because I think you're really reassuring and that's exactly what people need in this situation.
Thank you, Mark. Thank you for having me here again.
You're very welcome. It's Doc Talk with Monument Health.
You're not alone.